Yes.
And Dr. Galea, I've got questions on various different topics, so we'll have to dot about a bit. The first lot of questions relates to the schedules that you were telling us about that were brought in, I think you were describing when you were working in the Aberdeen Centre to work with clinical colleagues about the amount of blood that they were using. I've been asked to ask you whether it was your idea to introduce those schedules, and if not, whose idea it was.
Now we've lost sound.
We can't hear you, Dr. Galea.
Shall we just see if we can get the sound back?
Yeah, are we all right?
Right.
Sorry about that.
Do you want to start again? Did you hear the question? Do you want it repeated?
I did, thank you. It's all right, I've got the question. I think it was probably NSMBTS idea in general. The demands for blood were increasing. Number of donors were obviously about the same or getting harder to get the same number of donors. So any initiative to reduce blood wastage was considered to be a very useful one. Plus the context, of course, that we were beginning to think about the better blood transfusion project and how to reduce blood wastage in general. So when I was in Aberdeen, we discussed it, a number of colleagues in the blood center, me, Dr. Urbaniak, other doctors, and we began to establish these schedules. Did a lot of research, found out what the normal usage of blood was, when these were being used, began to set up our own local schedules, discuss them with the clinicians, and then implemented them.
And these schedules, were they in the form of written documents that were provided as guidelines to clinicians in different disciplines?
No, they were very simple. They were a simple table, and they were matched with the speciality. So if, for example, it was with the orthopedic surgeons, we gave them a square, a chart, and we said, total hip replacement, 4 units. Total knee replacement, 2 units. Revision hip, whatever, 5 units. And they would adhere to it. And once they agreed with the schedule, whatever request they made on the cross-matching form, we would stick with the schedule. If the request was, for example, if you're asking if the normal amount of blood used was 2 units and they asked for 6, we would phone up and say, is there a particular reason why you want more blood than average, and so on and so forth. So there was this dialogue taking place and a review every 6 to 8 months. I used to go, as I said before, I used to go to their committees and present the data.
Was the purpose of those schedules to try and limit the amount of blood which was being used?
Yes, because we know not to limit it, but to use the appropriate amount. At the time, many surgeons had very different views, and I'll never forget things like open heart surgery. Some surgeons, some particularly younger surgeons who had come from abroad, for example, were using 4 units of blood for open heart surgery. Others were using 10. And clearly, one of them is wrong. So it was that kind of dialogue. And normally, the blood ordering schedules ended up being on the conservative side. So we would put out 4 units of blood, say, for open heart surgery, if they required more, either before, because they knew that the patient was a difficult one, or afterwards. We could always provide them with extra blood as they required. But the routine was fixed, and that was really helpful.
And do you know whether or not those schedules were used in Scotland before your time as a consultant in 1989?
All I know is that I established them in Aberdeen. Whether they were used before in Edinburgh, Glasgow, or anywhere else, I'm not sure.
And did you ever discuss the benefits of using schedules and sharing information with clinical colleagues with anyone south of the border, so in England?
Not so much, because remember, in England, the blood services did not have the blood bank facilities that we have. So we were also the blood bank for the hospitals. This was more of a, if you like, a blood bank oriented issue. This was more to do with blood usage and discussion with the clinicians. My understanding was that in England, blood services were wholesale, and they sent blood to the hospitals, to the blood bank hospitals. So it wasn't a topic that particularly was discussed with the blood services, but I presented the data at various conferences, discussed at MSC and so on. So it was a well-known fact. And I would have thought, I'd be surprised if similar schedules weren't also used in England.
When did the system come in whereby the local hospital which transfused blood or a blood component reported back to the blood bank the details of the patient to whom the blood had been transfused?
Ever since I joined, they always had the requirement. So since 1984, the problem was that in the early days, they weren't very good at it. So the hospitals, weren't very good at returning the information. And it took a lot of time and effort to convince them that it was something which was important, it was essential for traceability, for audit purposes, for quality purposes, for licensing purposes. And I know, for example, that in Scotland, we had teams of nurses in hospitals going around explaining how to keep blood, how to make sure that these forms were returned, how to store blood, and so on and so forth, what questions to ask the patient before he got the blood to make sure that he got the right blood. So it was part of a big concerted effort that the numbers of returns of information returned, but it was always a requirement. We always knew that some patients got blood. That is how we were able to do the lookbacks, for example, because we had all the information.
What types of blood or blood components did you keep samples of? Was it everything collected at the centre, including plasma sent to PFC?
We kept samples of every donor that came. So it was one sample per donor. If you're talking about the archive, yeah. Obviously, we had samples for grouping, for testing. But if you're talking about archives, we always kept one sample per donor.
So if, for example,
on each time he came, each time he came, on each donation rather. On each donation we kept a sample.
So if you were producing any pooled components, would you keep a sample of of a batch of pooled components?
Not as far as I know, no, because we knew that a pool, say a pool of platelets, would be made up of 6 or 5 donations. So we knew where the donations were coming from because we had a sample per donor. So if a platelet pool got contaminated, we could exactly trace which one it was because we had a sample from each donor.
I'm going to ask you some questions about donors now. What medical information, if any, were you able to compile about repeat donors as their involvement with your service went on?
Well, the information we kept on donors were their basic demographic information, their data, their sex, their name, their address very often, their blood group, clearly each time, and we knew their blood group. And then we kept the records, their health check questionnaire, for example, they were all kept. And we would then, if there was any referral code that had to go on the computer, that was kept. But everything was done confidentially and on a need-to-know basis. So sometimes, if I wasn't on blood donor sessions, I wouldn't have access to particular donors whose blood was collected on that day, for example.
Would it have been useful to have had more access, or to have had access to more medical information on donors?
Can you repeat the question, please?
Would it have been useful to have had access to more medical information on donors? So we saw in the tick box questionnaire the consent form for the GP, and you thought that was an English form. would it have been helpful, for example, to have had the ability to seek information from the GP?
If there was a reason, we did contact the GPs quite a lot. If we had doubts, sometimes there were donors who would say, I've been to hospital and they wouldn't quite know why. I've got hip in my pain. What is the cause? I'm not sure. Then we had the ability to contact the hospital or to contact the GP via the donor and to get who the GP is and get information. But it was on an ad hoc basis. If there was no need to contact the donor, the GP or the hospital, there would have been no need. If, however, there was any queries, then yes, we did.
When you were telling us about the National Medical Register, one of the questions I asked you was what was the trigger for the for this coming into existence, and you spoke about high-risk donors donating in one area, donating or trying to donate in several areas.
Yeah.
Could you just tell us a bit more about that? What evidence was there of high-risk donors doing that, going from one to the other? Was that a common occurrence?
Not a common occurrence, but it was a risk, because if somebody was absolutely determined to find out whether he was HIV positive, for example, or he has been exposed to hepatitis and he wanted to find out, then if he went to Aberdeen, say, and he was refused, if he was determined, he might go to Dundee and say, I want to be a blood donor and can I find out? So to make sure that that didn't happen, because obviously having a unit of blood escaping to the net like that would have not been a very good thing at all. So we wanted to block that option, and therefore these patients, as I say, diluted with a few others, were put on this register so that they couldn't do that.
So is it right to understand that the National Medical Register was brought in to guard against a risk of something happening rather than because there had in fact been incidences where donors had moved from one area to another, high-risk donors had moved from one area to another?
To my knowledge, yeah, it was a precautionary step.
If a donor refused to do a hepatitis C test, or indeed an HIV test, would the transfusion centre refuse to accept a donation and any further donations from that donor?
If somebody was found positive for that test?
No, if somebody wouldn't consent to the testing of their blood for viral infections, what would happen?
We just wouldn't take the blood at all. That was a complete no-no.
And they would be deferred indefinitely, would they?
Permanent.
Yeah.
And I mean, obviously, that would be a question, with the nurse or the doctor, and say, why are you not consenting to this? Is there a reason? But if the donor refused to or didn't consent, then there's no way we would take a blood sample anywhere. No, ever.
Given that having unprotected sex is a risk for viral infection, was any consideration given in any of the many meetings and so on that you attended to consider material for exclusion of donors, to including in the high-risk categories any donor who had unprotected sex?
We discussed a number of issues around that. One was, for example, even in some of the high-risk categories, we said, even if you've had sex male to male once, even with a condom, for example, because we feared that the type of sex that they might have, the condom might burst, and so on and so forth. So we were very careful to even though some people do use safe sex and so on and so forth, we were very careful and fearful of risky activity. So if the activity was considered risky, then it didn't matter whether you used any protection or not. At the time, we felt you cannot give blood.
I should have been clearer. I don't mean male with male sex. I mean heterosexual, male-female sex.
I think, male-female sex, as far as I know, I'm not an epidemiologist, but the risk there was very much if you were, for example, if you had sex with an intravenous drug user, or if you had sex with somebody in sub-Saharan Africa, where the background prevalence was high. Then, yes, whether it was unprotected or not, we wouldn't take you.
So is it right then to understand that there wasn't consideration given to including in the high-risk donor list heterosexuals who had unprotected sex?
No. Except in the fact that, we at one point we discussed promiscuous activity, because I know that some countries have it as an exclusion criterion. If somebody has X number of contacts in a year or something. But I remember the discussion said something like how, whatever is called promiscuous is a very personal thing. Some people think X number is all right and other people don't. So we felt, that's going to be very, very difficult for a nurse or a doctor to exclude or to make a judgment on. And therefore, heterosexual sex in the context of high-risk activity was restricted to those activities that were listed in the leaflet.
Can we look back at a document that we looked at earlier, MACK 301160? And this is the letter that we looked at earlier from you to Professor Cash, dated the 16th of November, where you carry out the analysis of the differences between the English and the Scottish AIDS leaflet. I've been asked to ask you a question that arises out of what's said on page 3, which is the last, and it's the last paragraph. I think it's probably, if we can probably just pick it up. You're talking about the difference in the guidelines, and we can probably just pick it up towards the end of that paragraph. Although the risks from FFP and cryo is obviously much less in terms of donor exposure, FFP and cryo are untreated in contrast to factor VIII concentrates. Although epidemiologically the risks of exposure to FFP and cryo are less than factor VIII, I think that from a medical legal point of view, one should not accept such a risk, knowing that it exists. And I've been asked to ask you what you were referring to there when you referred to medico-legal risks, or risk in a medical-legal context. What did you understand the risks were in that context, and in what legal context?
From memory, I think the discussion was around whether we should include hemophiliacs in the list. Were they high risk or not? And there was a discussion around the fact that, by the time these leaflets were out, many of the hemophiliacs would have been given heat-treated products, and therefore they were considered safer, much safer than the ones before. And therefore, we stuck on, as far as I know, saying that we should only exclude sexual partners of hemophiliacs rather than including the hemophiliacs as well. And I know at one point, I am not sure whether there was a disparity for a long time between the English and the SMBTS version, but I know that in some versions, hemophiliacs were included, and in others, they were excluded because of what I've just said. So in some instances, we just had the sexual partners. In others, there were also the hemophiliacs included as well, purely because the risk of a hemophiliac of getting HIV after he was exposed to heat-treated products and other virally inactivated products was very, very small. And all right, you have some hemophiliacs who would have been exposed to FFP, which is very small donor exposure compared to a pooled product. But a pooled product is inactivated, whilst the FFP or cryo is non-inactivated. So the risk, it's a balance of risk, isn't it, between lower donor exposure but non-treated compared to a much higher donor exposure but treated.
We looked at the beginning of your evidence at the a makeup of the Medical and Scientific Committee, and we had a discussion about who was and wasn't part of that committee. And you may remember that there was on there the director of NSL. Can you recall what part the director of NSL played in the Medical and Scientific Committee?
He was an equal member of the MSc. National Science Laboratory was a laboratory that did research for SMBTS, and he was considered an equal part in MSc, what kind of research he could conduct, on which reagents, for example, or on blood groups, on genomics, whatever the direction that he was given by MSc. So although he wasn't directing a regional center or anything, but he played a very important part, and he was an equal partner.
And lastly, you mentioned in your statement that you say in your statement that you are not a transfusion infection expert, and I've been asked to ask you what would qualify a doctor to hold such an expertise? Is there such an expertise?
Well, if you look at the composition of SACTI, for example, which is the SAC on transfusion-transmitted infections, at least in my time, there was a mixture of virologists, epidemiologists. So they understood a lot about prevalence data and incidence data. Some people understood very well how the various test kits work, what was the meaning of a repeat reactive and how to avoid it and so on, which tests you would use for confirmatory assays compared to screening assays, which tests were appropriate for blood donor screening purposes compared to diagnostic purposes, because obviously they're very different. They have to be extremely sensitive, and also being able to have very high throughput numbers. So that kind of expertise, which clearly I don't have, there were people within the UK Blood Services that had it. And if you look at the composition of SACTI, you will get 2, 3, 4 people there who obviously had those credentials.
And were there anyone in the 3 blood transfusion services centres, that you worked in that held that expertise, or did you need to look outside the centres for that expertise?
I looked outside the centre in the context of, for example, I looked at it's called the NMRU, the National Microbiology Reference Unit of the SMBTS. There was Dr. Brian Dow. Before him, there was Eddie Follett. These were the people I used to go to if I had a query about a test result, and they would be able to help me out and explain to me what the issues were. So within SMBTS, there was expertise, but not within the RTCs. And on a UK-wide basis, then obviously there were some very, very, very well-renowned experts who I could go to if I wanted for advice as well.
So may I just turn behind me to see if Mr. Ross has any questions? No, he's confirmed he doesn't have any questions. So I have no more questions to ask.
Well, I have no questions.
Dr. Galea, is there anything you would like to add to your evidence?
No, I just hope that I've been helpful in the evidence I've given. It's not an easy task to remember things that happened 35 years ago or thereabouts. But I hope in a small way I contributed, and I hope that the outcome of the inquiry is fair and equitable and as you want it to be. So that's all I have to add.
Well, I'd like to thank you for the way in which you've given us such a wealth of information, in particular about ways and means of ensuring that, as you put it earlier, that the safest blood is the blood that's not given. It may be a well-used phrase by you, but it may well be used by us again. I wait to see. But you've certainly given us information about that and a lot about the care and selection of donors. And you might just like to know that in the short break before this part of the hearing, one of the core participants who'd been listening to you give evidence mentioned to me in passing, what a great witness, he said. There you are. And what a wealth of information you've given him. So you can understand why I'm thanking you.
Nice to know. Thank you very much.
So, sir, tomorrow we have Dr. Williamson giving evidence.
Yes, 10 o'clock tomorrow.